Yeah, I've got a little, I'm going to talk here a little bit about HIV and the law, and then Amy will transition to talking about trans issues and the law. And then if at any point there are questions, feel free to just intervene as we go here. Good morning. I want to thank first Craig Conniff, who put together this panel, who unfortunately also couldn't be here today, and for Amy as well for joining me in this discussion. My name's Trevor Hoppe. I'm a sociologist at the University of Albany. I study sex and disease and how we punish it. So kind of fun topic for today. There's a lot of terrain we could cover under LGBT privacy issues. Today, like I said, I'm going to focus on my research on HIV and the criminal law. In the 1980s and early 1990s, America was in the grips of an AIDS panic. A new disease was killing and maiming hundreds at first, then tens of thousands. For several years, the cause remained a medical mystery. AIDS was originally given the unfortunate moniker GRID, gay-related immunodeficiency, as it was decimating urban gay enclaves. The newly ascendant evangelical conservative right seized on this trend, declaring AIDS to be a, quote, cure for homosexuality. For the so-called moral majority, AIDS was divine retribution for moral decay. As I argue in my forthcoming book, Punishing Disease, from the very beginning of the epidemic, AIDS was tightly linked to punishment. The reactionary response to AIDS immediately sparked debates about health privacy that are largely forgotten today. These debates often pitted the interest of people living with HIV against the interest of the broader public. Many public health and legal experts wondered, for example, whether quarantine laws ought to be extended to give health officials more power to detain people living with a disease they labeled as, quote unquote, recalcitrant. Conservative columnists, if you're old enough to remember, you may remember some of their inflammatory commentaries, such as William F. Buckley, who explicitly argued that everyone diagnosed with HIV should be tattooed. A first key debate in the 1980s and 1990s concerned whether states should maintain a database that included the names of patients newly diagnosed with HIV. Epidemiologists called for these kinds of data systems for the sake of the integrity of their public health surveillance data. They wanted to make it all but impossible to double count new infections and to facilitate the tracking of people living with a disease over time. AIDS activists argue that this invasion of privacy was too risky in the face of a disease that was especially stigmatized and untreatable. Any unauthorized release of a patient's HIV-positive status could have devastating consequences. Indeed, if you, again, are old enough to remember, you'll remember the accounts of children being expelled from schools, homes of HIV-positive people being burned to the ground, employers hastily firing employees when they discovered they were living with the disease. Instead of names-based surveillance systems then, AIDS activists argued for code-based systems that facilitated the tracking of people living with the disease without the risk of exposing their identity. And I want to stress that this risk was not entirely academic. For example, in 1996, a Florida Health Department staff member, why is everything in Florida? I don't know. A Florida Health Department staff member was accused of using a health department list of over 4,000 HIV-positive people to screen potential sexual partners. I kid you not. And even more egregiously, he invited his friends to do the same. So the risk was not, entirely theoretical. Nonetheless, public health experts at the CDC strongly favored names-based systems and ultimately strong-armed every state health department in the country in adopting a name-based system rather than a code-based system. The final state with a code-based surveillance system switched over to names-based reporting in 2008. So that's debate one that I want to resuscitate here a little bit, and you'll see why in a minute. Debate two is over the adaptation of contact tracing for HIV. Contact tracing was developed in the 1930s in response to syphilis outbreaks. It involves asking newly diagnosed patients to disclose the names of their sexual partners so that the health department might inform them that they had been exposed. This system worked particularly well for syphilis because it's both highly contagious and treatable with antibiotic. As such, sexual partners of newly diagnosed syphilis patients were highly likely to have been infected or to have been the source of the infection. And once tested for the disease, there was something we could actually do. We could give them antibiotics and treat them and ultimately cure them. HIV is different than syphilis. How contagious is HIV? Now, most in the audience, I know you're not HIV experts, you probably think it's pretty contagious. So just out of curiosity, let me ask you a hypothetical question here. I'll do a little experiment. So if you just imagine a one-time sexual encounter without a condom between an HIV-positive man having sex with an HIV-negative woman, what do we think the odds of transmission would be? So how many hands for 100%? Close to 100%. Not too many, 50%? Couple hands, I see, 10%. Yeah, we're getting more hands. Okay, the answer is less than 1%, more like 1 in 1,000. So HIV is, in fact, quite hard to transmit, and it's harder to transmit than bacterial infections like syphilis or gonorrhea. So contact tracing isn't particularly well suited to diseases that are hard to transmit, and at least at times when these policies were being written in the 80s and early 90s, HIV was largely untreatable. So it's not highly contagious, it's not treatable, and so probably not well suited for contact tracing. Studies have actually suggested that health departments may diagnose more HIV cases using fewer resources with just random screening programs as compared to contact tracing. AIDS activists thus argued against that invasion of privacy posed by collecting the names of prior sexual partners. And it's not hard to imagine why. Just, again, put yourself in the shoes, a thought experiment here. You get a call from the health department, and they tell you someone you recently had sex with has tested positive for HIV. Now, imagine you've only had one sexual partner in the past 6 months, and I know this might be harder for some than others. So if you've only had one sexual partner, right, it doesn't take a rocket scientist to figure out who this person that they can't name because of HIPAA, but you can sort of deduce by not too much logic. There are instances of married couples, for example, partner services, hard to imagine. So there's no way for health officials to anticipate this, right, because they know the sexual history of the index patient, but not you, the referred partner. So that's the privacy risk sort of at play here, and I want to add a layer to that in my talk today. But despite these problems with name-based surveillance and contact tracing, they're basically universally practiced across the country. And this is true for HIV and other STIs as well. This practice has never been demonstrated to be a cost-effective use of resources. Instead, many health officials just believe it's a good idea. These debates over contact tracing and name-based surveillance mostly fizzled in the 1990s. Today, I think it's necessary to revisit them in the face of increasing criminalization of people living with HIV. What do I mean by criminalization of people living with HIV? In the 80s and 90s, at the same time that these debates were playing out, many states across the country passed new criminal laws that made it a crime, generally, for people to have sex with someone without disclosing their HIV-positive status. I'll refer to these laws today collectively as HIV exposure and disclosure laws. Virtually all these laws in the US do not require the prosecution to show that the defendant's partner contracted HIV because of their actions, or even that there was any risk of that outcome. The vast majority include felony penalties that can result in prison sentences upwards of 20 or 30 years. In some cases, in some states, conviction requires registration as a sex offender. While these laws were written at a time when AIDS was a terminal illness, medical treatments have transformed the disease. Many of you probably are aware. It's now more of a chronic, manageable disease than a terminal illness, in many cases with a 1-pill-a-day regimen. Yet despite the medical and scientific advances in the more than 3 decades since most of these laws were put on the books, we're still stuck with the laws based on 1985 science. Now, some in public health have reluctantly spoken out against criminalization, but practitioners in the field have rather mixed opinions about punishing disease. In some cases, public health departments have quietly engaged in policing-oriented policies that have transformed their work from public health to law enforcement, and that's what I'm going to talk about today. One way in which health departments have reoriented their work towards policing has been to harness the names-based disease surveillance systems that I talked about earlier for law enforcement purposes. These systems were intended solely to facilitate epidemiological surveillance, right? The data integrity was the goal here. They were never meant to be systems of recourse for police or for other kinds of investigations into people living with HIV. Yet my research in Michigan, as well as reports from numerous other states, reveal that this is exactly what's happening around the country. So what did I find in Michigan? I interviewed health department staff in 14 of the 17 jurisdictions in the state that have staff dedicated to managing HIV. I asked these officials how they identified people they suspected were what's known as a health threat to others, a legal designation that can have far-reaching implications. Today, I want to relay a few practices to me that suggest a policing orientation to public health practice in what they told me. The first practice is the cross-referencing of name-based surveillance systems and contact tracing, those two debates that I talked about earlier. So how does this work? Let's think about this for a second. You test positive for syphilis, gonorrhea, chlamydia, HIV. In any of those cases, the health department's going to give you a call. And they're going to say, who'd you have sex with? Contact tracing, right? And let's say, you tell them you had sex with Joe, Larry, and Bob, we'll say. In several jurisdictions, they tack on a second question. It's not standard practice. Did Joe, Larry, or Bob ever tell you that they were HIV positive? And say, no, Joe, Larry, or Bob, nobody told me that they were HIV positive. Note that they'll ask you this question whether you test positive for HIV, syphilis, gonorrhea, any of those reportable infections. The health department staff member will take that information and launch something of investigation. In some cases, health officials told me that they might automatically recognize the names of Joe, Larry, or Bob. If they don't recognize any of those names, they'll then call the state health department to ask if they run a search on the names-based surveillance system to find out if any of them has been diagnosed as HIV positive. If they get a match, let's say if Larry is found out to be HIV positive in the previous example, they'll investigate further and in some cases encourage the index patient to call the cops. Of course, they can't tell the original index patient that someone, the identity of the person who's named as, the named partner who's HIV positive. That'd be a violation of HIPAA, right? But officials describe tiptoeing around HIPAA here. Let me quote a Michigan health official I interviewed to paint a picture for you. There's a lot of tiptoeing, she says. There's a lot of, well, we'd like you to come back into the office and talk to you a little bit more about your situation. And that's when we'll try to say, have you had any other partners? Have any of your other partners said anything about being HIV positive? And at that point, sometimes we might say, well, we'd like you to report this to the police. Anecdotal reports from outside of Michigan suggest this practice is more widespread. For example, during a Tennessee court hearing against an HIV positive man accused of not telling his female partner that he was positive, describes that she learned of the defendant's status from health department staff directly, a clear violation of HIPAA. Quote, the victim stated that she went to the health department on November the 27th of 2001, tested positive for STD, they don't say which, and at that time she gave the suspect's name to the health department and was told that he was HIV positive. Reports like this suggest that at least some health departments in the country are developing a policing orientation towards their public health practice. This was evidence in a range of policies, not just the practices I just described, but also, for example, in the quote-unquote client acknowledgement forms that many health departments ask newly diagnosed patients to sign. These are essentially forms that say, I know that I'm HIV positive, and if I do this or that, I'm going to go to jail. These forms were specifically designed to facilitate holding HIV positive clients legally responsible. Health officials explained to me that these forms were necessary because some individuals diagnosed as HIV positive would later claim that they had never been told of their status. And in this case, ignorance would be a legal protection. You must know you're HIV infected in order to be prosecuted under these laws. Forms like these have been introduced as evidence in criminal cases in Florida, Indiana, Mississippi, North Carolina, and Tennessee, just to name the ones, as well as Michigan, that we're aware of. Although the health department staff cannot itself file criminal charges against defendants, a partner has to go to the police, there was limited evidence of attempts by health officials to solicit sting operations against their clients. For example, in 2009, a health department in northern Michigan wrote to the county prosecutor to report an HIV-positive client they suspected of being a health threat to others. And in this memo that was obtained by a local journalist, they suggested 3 options, one of which was that the police set up a sting operation at the public restroom to catch this individual. Again, policing-oriented orientation towards public health practice. You might think that this pattern of practice would mean that public health practitioners assign significant public health value to disclosing one's HIV-positive status. But even this assumption appears faulty. In a survey that I conducted with the officials that I interviewed for this study, only 44% agreed with the statement that, quote, laws requiring that HIV-positive people disclose their status before having sex help to reduce the number of new HIV infections every year. Yeah, despite that less than half believe that these laws contribute to public health, 0% agree that they should be repealed. This suggests that the value of these laws in the eyes of health officials is not solely a function of their public health utility. There's good reason to believe that promoting status disclosure is not necessarily beneficial for public health. How could this be? It would seem obvious if a person was informed of another person's HIV-positive status, they'd be better able to protect themselves against infection. That's the sort of logic of disclosure, right? But there are two problems I just want to point out briefly with this argument. First, most HIV infections are the result of having sex with someone who had no idea that they were infected. In other words, someone who could never have disclosed, even if asked. This is because the virus is unchecked in their bodies, reproducing millions of copies of itself that permeate the person's bodily fluids. This makes it much easier to transmit the disease. Second, many people who go on treatment today, you may know this if you're in the healthcare field, achieve what's known as an undetectable viral load. This means that latest scientific tests cannot isolate the virus in their body. The treatments have effectively squashed the ability of the virus to reproduce in their body. Recent studies have confirmed what many HIV experts have suspected for many years, that people with undetectable viral loads cannot transmit the disease. This was most strikingly evidenced in the recent partner study, which observed gay and straight couples in which one partner was positive and the other was HIV negative. To participate in the study, you had to be having sex without a condom at least some of the time. They followed these people for years to see how many transmissions took place, right? After an estimated 58,000 condomless sexual encounters, 58,000 is sort of a staggering number, there were zero link transmissions between partners in the study. And this is the best evidence we have now to support this claim that activists, they have this new message that undetectable equals untransmittable. Without a clear public health justification for these laws, health departments must stop aiding in their enforcement. The health department should not become the police, and they ought not to use disease surveillance systems for law enforcement purposes. At the very least, they ought to be much more transparent about how they use the information they do collect. Until this happens, I believe gay men, LGBT people, and members of other communities disproportionately impacted HIV have good reason to refuse cooperation with local health department investigations. We should not be made unwitting tools of an effort to punish the sick. Thank you.
Thank you so much, Trevor, and good morning, everybody. I am Kellan Baker, your moderator. Move this off the screen. 1 second. I apologize for my tardiness. I came down from Baltimore this morning, and your privacy settings here were set so high, I had a hard time finding the room. But I'm here, I'm queer, and I'm excited to talk with you all about health privacy in the LGBTQIA, that is LGBT, queer, intersex, and asexual community, electronic health records, and sensitive data. And I'd like to thank the moderator from the previous session for getting us started, and Trevor for diving right in. And with no further ado, I would like to invite Amy Nelson, the Director of Legal Services from Whitman-Walker Health here in DC, to tell you more about Whitman-Walker's experience with these topics. Amy.
Good morning, everybody. I want to congratulate and thank Deborah and Amber for putting together this amazing event, and thank you all for being here, and thank you to my co-panelists. Specifically, I want to thank Trevor for that stirring reminder of the stigma and ignorance surrounding HIV, a stigma that unfortunately continues to flourish today. I work at Whitman-Walker Health here in DC, where we provide medical care and support services to more than 15,000 individuals on an annual basis. And of those folks, about 3,000 of them are living with HIV. Now, of course, this is a service we've been providing at Whitman-Walker since the onset of the disease. The difference, of course, is that today our HIV-positive clients are living healthy lives and, for the most part, have their HIV well under control. But back in the day, we as a health center were in the crosshairs of some of the public official paranoia that Trevor described. Officials who were seeking to uncover the names of persons living with AIDS in the 80s. And so what I understand about the very colorful Whitman-Walker history is that at one point, the staff actually maintained dummy patient files in the front office so that if and when government officials showed up wanting to seize patient records, the real client names, patient names would be safe. I also understand that we used to be home to an anonymous and questionably reusable coffin, and that is because surviving partners and families simply were turned away by local funeral homes. Point is, advocates and allies went to great lengths to protect the needs and protect the dignity of the community. So from those early days, back in 1986, Whitman-Walker hired its first lawyer because some of our AIDS patients were being discriminated against at local hospitals and by others. So 31 years later, we're still at it. We pride ourselves in being the nation's oldest medical legal partnership. So today we still offer free legal services, and that's my job. I'm the director of legal services. There are over 20 of us in this department. So we help more than 3,000 people a year. About half of those people are living with HIV. A third of those people identify as lesbian, gay, or bi, and 1 in 5 identify as transgender. The folks who seek us out in legal tend to have poor health, or rather heightened health concerns and less stable income and housing than the average Whitman-Walker patient. We help folks with legal issues including discrimination, immigration, elder law, public benefits, and other matters related to health. And one of the services we offer relates specifically to medical privacy, specifically privacy around one's gender identity, their sexual orientation, and/or their HIV status. So when do clients come to us in legal? Well, they come to us when their employers fire them. They come to us when their colleagues taunt or harass them at work. They come to us when their teachers expel them from school or refuse to control peer bullying. They come to us when their landlords kick them out. And finally, and perhaps most heartbreakingly, they come to us when their families disown them once they discover or even suspect that one of those 3 characteristics may apply to their child, their spouse, their classmate, tenant, or coworker. So today, that's a big umbrella of stuff. Today I want to focus on gender identity. As Trevor so carefully outlined, American homophobia has led to tangible efforts to criminalize queer behavior. Unfortunately, I think we can all agree those stigmatization efforts don't end with HIV or gay sex, but rather those systems have systematically targeted persons who are not gender conforming. Folks who identify as transgender, gender variant, or gender expansive. And I'm not talking about a small number of people. According to the Williams Institute at UCLA School of Law, more than 1.4 million adults in the United States alone identify as transgender. So 1.4 million is a lot of people. That's about the size of the city of San Diego. And we know from other surveys that transgender folks are particularly struck by poverty, discrimination, and violence. And we know that Black and brown trans people are disproportionately affected by those same issues. And as a result, the health impacts on those communities are staggering. Again, according to another Williams Institute study, trans folks report a higher prevalence of poor health outcome and report more days per month of poor physical and mental health than their cisgender counterparts. And perhaps most strikingly, the rate of HIV among transgender persons is staggering. The rate is 5 times that of the cisgender population in the United States. So 5 times among transgender folks, the rate of HIV. But when you talk about trans women of color, a subgroup that we talk about a lot because of the health disparities, their rate of infection is 22 times the national average. And more studies tell us that trans people tend to lack health care, they tend to lack health insurance, and they tend to lack access to a competent provider. In fact, we know that many people report being discriminated, verbally harassed, or simply refuse treatment because of their gender identity, and that's one of the types of cases we take at Whitman-Walker. Today, I want to talk a little bit about the evolution of coming out of the trans closet. That is, the growing social, legal, and medical recognition of the journey of transgender people, and specifically the need for transgender medical care, and how that evolution has collided with medical record keeping and implicated medical privacy concerns. So I think this group will be excited to hear that I want to talk about data collection. With so many actors in the healthcare puzzle, particularly electronic medical records systems, these actors are all struggling to catch up with the notion that gender requires more than 2 checkboxes. M and F is not enough. In fact, gender requires more than one question. Specifically, adequate EMR systems often lack fields to collect sex assigned at birth, current gender identity, or preferred pronouns. We at Whitman-Walker are living through this as we push our software provider to update what they thought was an adequate system when they established those templates. So as EMR software engineers strain to catch up, insurance claim systems are equally suffering, and of course sometimes refuse to pay claims when gender markers don't match. But unfortunately, it's the patient who feels the pain firsthand when medical providers and office staff call for or greet the patient with the wrong name or a mistaken pronoun, or in some cases, refuse to provide service to that patient at all. And data collection, of course, influences insurance coverage. A popular excuse for denying insurance coverage was the so-called pre-existing condition of being trans. We joke about the trans broken arm syndrome or the trans root canal, where insurance companies denied payment or doctors refused to treat the patient simply because the patient happened to be trans. And they knew that because there was a descriptor in the client's medical record. But of course, that status was completely unrelated to the medical need at hand. Thanks to the current law of the land and the Affordable Care Act, Obamacare, we are not at the mercy of pre-existing conditions. But let's hope that remains the case. I think we all know that the alternative bill passed by the House would give states the option of allowing reinstatement of pre-existing condition coverage limits. Obviously, this would hurt a lot of people, including trans folks. Folks with a history marker in their medical record of being trans, or perhaps being a sexual assault victim, a victim of domestic violence, or perhaps having had a C-section would be in danger of losing or at least paying more for their coverage. Thanks to the Affordable Care Act, healthcare has evolved, but with growing pains. The positive development, insurers and employers are now readily covering most healthcare needs of transgender plan members. That is, when the healthcare is not related to being transgender. So most broken arms and most root canal claims are paid for. But the challenge remains that some insurers, I should say, are openly denying coverage to trans individuals when that care is related to the patient's medical transition, when that care is medically necessary. Specifically, access to hormones and surgery. So for example, we get a lot of calls from clients who may go to the pharmacy wanting, let's say trans man wanting to fill his testosterone prescription, and the pharmacy says, okay, that'll be $100. And the guy says, well, I pay $10 copay for all my other prescriptions, why is this more? And they say, well, your insurance company has denied the claim, and that could be for a variety of reasons, and that's where we step in and attempt to problem solve. Now, before coverage of trans care was even a glimmer, many providers would simply list a code in the record that did not mention gender dysphoria, or at the time, GID, gender identity disorder. It's since been renamed gender dysphoria. So for example, in that testosterone case, a provider may simply list a condition as endocrine disorder not otherwise specified, and then the claim would go through. Some surgeons followed this lead and used other coding to secure gender-confirming procedures. While this approach ignored trans identities, it resulted in transition care. Today, accurate diagnostic codes are the norm, and advocates like us at Whitman-Walker rely on a variety of legal arguments to ensure coverage. One such tool currently under threat from this administration is the Section 1557, which is the anti-discrimination language within the Affordable Care Act. So we use that to fight cases, and in nearly all cases we win. But, and there's a huge but here, the process is incredibly complicated. First, an appeal can span many months, even years, leaving the patient without medically necessary care that they need or sitting on piles of medical debt. And second, some clients may choose not to pursue the appeal at all because the insured primary party, which could be the patient themselves or a spouse or a parent, does not want to reveal the medical transition to the employer. This is particularly relevant in the case of an employer who may be self-insured. So the insured person simply doesn't want to pursue the claim, a real fear despite HIPAA protections. So I've seen multiple cases where young people who are in their early 20s are still on their insurance plan, are seeking transition-related care, and then once that care is denied and appeal needs to be pursued, we contact the parent or the child contacts them on our behalf, and the parent says, you know what, let me just pay out of pocket or pursue another avenue. I don't want to pursue this appeal because I don't want to rock the boat at work. Because in addition to fighting the insurance company, we may in some cases file a Title VII discrimination claim against the employer. And of course, there's a lot of stigma around trans identities, and so the parent may not want to out themselves to their coworkers as the parent of a trans child. So in these cases, we help the patient pursue other insurance or payment options if any exist, but this is obviously not an acceptable outcome. There is one little piece of good news around gender dysphoria being a medicalized condition, is that the diagnosis can be used as a shield with some third parties, such as employers, schools, and the courts. Even when that receiving party is not a HIPAA-covered entity, but the mere mention of the word HIPAA scares them. Specifically, we've argued to local courts that a name or gender change petition should be sealed to protect the client's medical privacy, and we have prevailed. Some local statutes mention medical privacy specifically, while others talk about sensitive information, and in either case, we can use that language to our advantage. So, in closing, medical privacy around gender identity can be messy. Who needs to know, and how will they respond? Like HIV, ignorance and stigma, if left unchecked, may stifle the conversation or push it in the wrong direction. But access to transition-related care has gained more momentum than ever. The medical and insurance communities are starting to figure it out. We have a long way to go, but we're headed in the right direction. Thank you.
Thank you very much, Amy. And before we go to Q&A, I just want to give a brief overview. As I mentioned before, my name is Kellan Baker. I'm a senior fellow at the Center for American Progress, which is a progressive think tank here in DC, where I work on LGBT issues and data collection issues. And I want to give a brief update on a study that I have been involved with for the last several years called the Emergency Department Query for Patient-Centered Approaches to Sexual Orientation and Gender Identity. We somehow got that to be the Equality study. Don't ask me where the acronym actually comes from. What that study is about, it started in 2013. It's a collaboration between Johns Hopkins and Harvard Medical School. It is related to, as the name suggests, the collection of sexual orientation and gender identity data in one of the most fraught spaces for patient privacy and concerns, the emergency department. So the Institute of Medicine and the Joint Commission, as I'm sure many of you are familiar with, have recommended the routine collection of sexual orientation and gender identity data collection in clinical settings, particularly in electronic medical records. And the Meaningful Use Program and the subsequent MACRA program have included a requirement that certified EMR systems be able to collect, retrieve, and use structured data on sexual orientation and gender identity. That's not a requirement that any provider or any particular clinician has to ask these questions of their patients, nor is it a requirement that patients disclose this information, but it is a requirement that these EMR systems have the capacity to collect these data, meaning that nature abhors a vacuum, right? If there's a question there, the likelihood that that patients will be asked these questions increases. So this study was looking at, as I mentioned, the emergency department, and really what it focused on was looking at whether or not patients, sexual orientation and gender identity minorities, sexual and gender minorities, are willing to disclose data related to their sexual orientation and gender identity. And again, this is in the emergency department. So if I were to ask you all, what percentage of sexual minorities, LGB folks, would be willing to disclose their sexual orientation if asked in the emergency department? 100%? 80%? Anybody? 0? I see some votes for 0. Well, we asked a bunch of clinicians, and clinicians said, as many of you here have said, well, we expect about 80% of people would refuse. Actually, 10% of sexual minorities would refuse to disclose their sexual orientation if asked in the emergency department. These data come from, we did a mixed method study. So we did some qualitative interviews here in the DMV metro area with patients and providers in order to put together a questionnaire that would get at this question of would you disclose sexual orientation or gender identity information in this setting. And then we took it nationwide to a survey of more than 1,500 self-identified LGBT folks, as well as about 450 providers. And these are where the numbers came back, that about 80% of providers in the emergency department anticipate that their patients would not share data related to sexual orientation or gender identity. Whereas when you ask the patients themselves, only 10% would refuse. So that sets us up for some very interesting discussions down the road. LGBT folks, when asked, gave a couple of different reasons for why they said they would share this information. They talked about recognition of who they are and what their families look like, what their specific health concerns might be. They talked about normalization, the desire for these questions to be asked more regularly as part of the recognition that LGBT people are everywhere, including in the emergency department, and the degree to which sexual orientation or gender identity, and particularly as Amy has just mentioned, gender identity being very relevant in many cases to the provision of care. Maybe not when it comes to a broken arm, but there are a variety of circumstances in which knowing your patient's gender identity is actually quite important for making sure that that person gets the right care. So finally, in terms of some of the last few tidbits of findings from this study, confidentiality, assurances of confidentiality were less important to LGB patients than a private space to fill out the form, and patients preferred nonverbal self-report. So on a paper form or an iPad where they were not asked by a provider, but where they had the opportunity to input the information themselves. So this study was just released. The sort of first wave of papers is coming out. You can see it in JAMA. It came out in April of this year, and again, this is the equality study. So I will be happy to answer any questions about that study, but I wanted to open it up to general questions for all of us here on the panel, and if you could please join me in giving our panelists another round of applause for their awesome presentations. And do we have any specific questions for myself, Trevor, or Amy?
More toward Amy. Amy, my name is Stephen Cosby. I do group health plans for a living, and it was more just a comment. You mentioned that guaranteed issue was out there as far as no medical underwriting. I just wanted to let you know that medical underwriting is alive and well. There's a gaping hole in the law that employers have been taking advantage of, and they've been self-insuring and medical underwriting small groups, and the administration has failed to address it, or the previous administration. So in your quest to, fulfill your mission, don't ignore that or turn a blind eye to that. They're still asking medical questions. I deal with it every day. It's a challenge, and I wish it had gone away, but it's there. It's alive and well. So.
Yeah, thank you for that comment.
Question?
Adrian Gropper. My role is to pay attention to technology as it relates to health privacy. From the perspective of you, this community that you panelists represent, are there roles for technology or improvements that you see would be important?
I have some thoughts I want to invite.
Well, I think I touched on that a little bit, simply that technology has a long way to go in terms of collecting SOGI data, so that's our shorthand for sexual orientation, gender identity data. We, in legal services, we use an online database to track our legal work, and it's pretty malleable, so we've been able to expand those fields, but the EMR is a clunkier machine, at least the one that we use at Whitman-Walker. So I do think there's a long way to go in terms of normalizing what the data collection process looks like so that it's simple. And as Kellan said, if it's not safe and straightforward, folks may not disclose that data.
One of the most important things that I see coming up, in addition to what Amy mentioned, is the need for stratification of privacy settings on records. So we have a lot of concerns from LGBT individuals. They want to make sure that the providers who need that information can get that information, but they also want to make sure that any random person walking past a computer can't necessarily dial it up and figure out who is the transgender person down the hall. So I don't know the degree to which you've been involved in any work, for example, that might sequester information about, for example, a previous abortion or birth control access, anything, or psychiatric information, anything that might be a little bit more sensitive from a patient perspective, and whether that is applicable in the LGBT patient setting. But we also have a balance there between, as these respondents mentioned, normalization, wanting this to be a certain degree of basic demographic information, while also recognizing that some other individuals might have more specific privacy concerns. And how does the technology of the EMR reflect that?
To the extent that I am involved in, you asked the question, I'm not aware of any practices, best practices, that are being promulgated by the vendors, either in terms of how the EHRs, and Shahid left the room, actually, he would be a good person, or in the exchange of information. There's a lot of activity in trying to label and filter stuff, but not, as far as I can tell, something where there's a contribution by the community to say, this is what we must have, this is what is nice to have, for example, or anything like that. If there's anybody in the audience, maybe they would chime in.
And in particular, given the requirements under federal law for the different treatment of patient data related to psychiatric treatment, I would love to talk with anybody afterwards, or if you have contributions, I'd love to hear that. Another question over here?
I was curious if you had longitudinal data about the willingness to disclose, because I think people are a lot more comfortable now, or seem to be, on both sides of the fence, in disclosing and hearing it, so to speak. Have you got any?
We do not have longitudinal data from a single cohort, but we do have a couple of studies over the last couple of years that have shown an evolving willingness. In my work at the Center for American Progress, we've done several nationally representative surveys and have asked, would you be willing? And we have consistently seen above 75% of both sexual minorities, so LGB folks, and gender minorities, so transgender folks, saying that they would disclose this information to their healthcare provider if asked. But there definitely is a trend, but I was myself surprised to find out that that trend started at over 70%-ish several years ago. Question?
Hi. All right. Okay. Looks like this works. My name is Lauren Harriman. I'm an attorney in California and also an engineer. It's a strange combo. Questions for Kellan. In the equality study, so most patients don't know that they don't have to give their social security number when they're in like a doctor's waiting room or what have you. So what sort of precautions did you take to make it clear to patients that they didn't have to give you the gender information if they weren't comfortable doing so?
There was no particular information on the form that said this is not compelled disclosure, so it sort of rode along with the other types of information that you mentioned, for example, the social security number. I think that's a really good point. The degree to which, myself as somebody who considers myself pretty informed about my rights, and I'm sometimes confused about what information I have to provide. Yeah. So that is something that I agree going forward in this study. That's something that we'll need to make sure to keep an eye on. Do my fellow panelists have other thoughts on this question of what do people know? Do they know their rights, and how do they assert them?
Well, when we do intakes on the legal side, we certainly make it clear that that responding to the questions is optional. However, most people come to us because their issue is related to one of those underlying characteristics. So usually it's front and center in the conversation.
Thank you.
Thanks.
Hi, my name is Lisa Max Barra. I work for the California Medical Association, so I mostly represent providers. And we see this issue coming up more and more with the treatment of particularly transgender patients. And I think, in California, we are pretty progressive in our laws. The only issue is a lot of times the laws are written so that the patient will, or the individual self-identifies, and that's what goes on the public record. And as you mentioned, the EMRs are not sophisticated enough to capture the different nuances, and in the medical context, it's actually an issue, because if you're a transgendered patient, your medical needs may be different than what you have just self-identified as. And so do you have any suggestions to how to kind of change that discrepancy, whether that's going to come from the technology side or from maybe a regulatory or legal side?
Kellan, you want to address that?
The recommended, so there currently is no single standard for how to collect data on gender identity in an EMR. But as Amy mentioned, there is a gold standard, if you will, that has come out of the world of population surveys that is a two-step question. So first it asks, what is your current gender identity? And then it asks, what is the sex that you were assigned at birth? So there has been a lot of work. For example, the World Professional Association for Transgender Health, WPATH, has an EMR working group that has published recommendations for how to incorporate the two-step question into an EMR, and then how to link that information from each of those questions to clinical decision support that actually makes sense. So for example, on the basis of the sex you were assigned at birth, you would then have an anatomical inventory, or you would have something linked to recommended screenings. For example, cervical pap tests for transgender men, individuals who were assigned female at birth and may or may not still have a cervix and need a pap test. And then the information about current gender, more driving things such as how do you address the patient, current issues such as transgender man, are you on testosterone therapy, et cetera. So that is really the main way that I've seen these systems attempting to respond to the reality that transgender people may have medical needs that are not immediately apparent on the basis of their current gender identity, but that should be available, data should be available in the EMR to make sure they're getting that care.
Do you know where we are in the implementation of that in terms of sort of the big actors in the EMR world?
We're working on it.
Okay.
So Epic, for example, has been in discussions with experts in this field for quite a while, and they're working on incorporating that two-step question into their sort of out-of-the-box, off-the-shelf product. We have seen a couple of major medical centers in California. Actually, the University of California at Davis was one of the first places to really pioneer the collection of these data in the EMR. So it's really sort of happening piecemeal. We were hoping that there would be a stronger statement from the meaningful use regulations that we really do need to have a two-step question. It's not enough to say transgender, because what does that mean? And how do you make sure you're addressing the patient appropriately and caring for them correctly? But it really is sort of happening very piecemeal. But I recommend to anyone there are two actually articles in the peer-reviewed literature from the WPATH EMR working group, and they describe in significant detail how to actually implement this in an EMR system.
Great, thank you.
Thanks. Yeah.
Hi, Amy, you had mentioned that you leverage the regulations in ACA to advocate for your patients. With the new administration and the new American Health Care Act, particularly in pre-existing condition that is a little bit nebulous going forward, what are some of your concerns and how are you addressing that on behalf of your patients?
Right, thanks for that question. So we are very concerned because the anti-discrimination section of the Affordable Care Act 1557 is still the law of the land, but enforcement by the Office of Civil Rights at HHS was enjoined by a federal court in North Texas, embarrassingly my home state, on the last day of 2016. And so the Office of Civil Rights, OCR at HHS, hasn't been taking any action to enforce 1557. Now, on the flip side, folks have been pursuing their rights under that clause in federal court with some success. So between that and, as I mentioned, Title VII, depending on to what extent the employer is implicated, we feel like we're optimistic. The hope is that the fight in federal courts can march forward, despite what may happen.
That even if the roof burns off, the walls may still be standing. That's kind of how I think about it.
Yeah.
Thanks, Amy. Good question.
Yeah, good morning. My name is Gerald Schatz, and apart from slipping on stairs, I'm a lawyer. And you had asked about different practices among the research sponsor agencies. I would point out that the National Institute of Justice is subject to 42 USC 3789G, which provides criminal penalties for unauthorized disclosures. On the other hand, the common rule agencies give behavioral and social science research almost a free pass from scrutiny.
Thank you. Any more questions. I have one that I would like to ask of Trevor really quickly, and actually this is sort of for Amy as well. Just in the sense of, as we're wrapping up here, how do you think current trends, you mentioned quite a bit about the state level, but also obviously local jurisdictions and the national level, how do you see these trends further exacerbating the vulnerability of patient privacy, particularly for LGB folks and people living with HIV?
Well, it varies so much by jurisdiction, and I think that's important to always keep in mind. So, if you live here in DC or in San Francisco, your health department is probably not engaging in the practices I've described. It's happening in places where criminalization is more rife. The South, the Midwest, more conservative states. So in those places, I think that's where we have to look. That best practices that make sense in San Francisco may not make sense, or need to be adapted somewhat in places where the stigma is not the same. Does that?
What do we do if we live in Dubuque?
You move. It's a challenge. I mean, I think many people, I know HIV positive people who have made a decision to move across the country. I know transgender people who have made a decision to move across the country because they couldn't get the health care they needed, or they couldn't, they were being surveilled and policed by their local health department. So if you're unable to move, I don't know how you manage that. I mean, I think unfortunately the stigma leads to less disclosure rather than more, because you want to contain who knows this information. And so I think it actually, it reduces the amount of disclosure that happens rather than increases it in these high stigma environments.
Mm-hmm. Well, and hopefully, I guess we'll have our national protections for as long as we can in terms of non-discrimination.
I just want to throw out one thing we haven't mentioned, which is RFRA. I think we all know that it's looming there in the background. And of course, it wasn't, it was invoked in one of the more recent executive orders, but it didn't target LGBT persons specifically, something that we were expecting to have happen. I do think that RFRA is going to gain traction in terms of a tool that folks can use to discriminate against LGBT persons, particularly folks with extreme health needs.
And could you say really quickly, what is RFRA?
RFRA is the Religious Freedom and Restoration Act. So that's the federal level, and then states have frequently, many states, I don't know how many have enacted their own RFRA-like state law.
Well, we are right at our time for wrapping up. I want to thank you all for being here, and one more round of applause for our panelists. Thank you very much.
Let me thank all of you for this incredibly nuanced and important discussion, particularly about medical records and stigmatization. And well, as a psychiatrist, certainly I've been working for a long time with stigmatized populations, and it's very, very difficult to make decisions about what to reveal and to whom and what will happen to it. And so I think you brought a much higher, a more nuanced level to this discussion. But we're always going to have stigmatized conditions. And people should always have be able to make their own choices about who knows what about them. And so it's an important problem to, and hopefully everyone doesn't have to keep moving, that there should be ways, of course, to segment sensitive information and for you to decide who sees it. And anyway, thank you. This was just amazing. Thank them again. And.